Well, good morning, everyone, and thank you for managing to make it in today. What a snowstorm. Anyway, one of the things that brings me great pride, passion, joy is talking about this program of research that I've kind of embarked on with help from many clinicians that I've worked with at Toronto Rehab. I have nothing to declare, no conflicts of interest. I work with a great, wonderful group. One of the sort of lovely things being a nurse is that I've been able to work with an interdisciplinary team, sort of surgeons, physiotherapists, epidemiologists, geriatricians, physiatrists, to try to really look at what is best care for people with a hip fracture, particularly if they have a cognitive impairment. How do we get them to sort of where they were prior to how do we get them back home if they happen to fracture their hip? And I'm thinking about our snowstorm today, and unfortunately we will see a few extra elderly people in our emerge, probably today and tomorrow. The objectives for today's seminar are to explore factors that predict older persons' function and mobility at 6 months discharge from rehab, to explore factors influencing reintegration into normal living for older persons post-hip fracture at 24 months discharge from rehab, and to also look at current gaps in providing rehab to older adults post-hip fracture surgery. I want to just give you a little bit of a background, and I'm pretty sure if you do work with the elderly, you know this. Hip fractures are a common injury resulting in major impairment in mobility and function. 31% to 65% of older orthopedic patients have dementia and/or delirium, and we do notice that it's quite high for persons that have had a hip fracture. We also know that patients with cognitive impairment, so and I define this loosely as anyone with a dementia, a delirium, or perhaps both, are often refused entry into inpatient rehab units. And I don't know if this phenomenon happens within your hospital, but I know it surely was the case in Toronto Rehab about 10 years ago. Patients with hip fracture and cognitive impairment, this is a huge issue. Dallas Leach just wrote a wonderful paper in JAGS. He basically realized that up to 40% of individuals with dementia receive no formal rehab after a hip fracture, and you can imagine with our demographics, we're going to see more and more persons that are older with a dementia. He did look at 4 different cohorts in his work. He looked at individuals that had no rehab, persons that ended up going into complex continuing care, where you usually have slow rehab, slow intensive, longer duration rehab, home care rehab, or inpatient rehab, which is often the more intense sort of gold standard for people that actually need rehab. He did find that only about 27% receive the most intensive form of rehab. Of course, when he looked longitudinally, he found that persons that did receive some home care or intensive rehab had the lowest risk of long-term admission and death. I think that's a no-brainer. The more rehab we get, usually the better our outcomes are, and that's with any type of rehab required. Post-fracture rehab for older persons with dementia is also associated with lower risk of long-term care placement or mortality. So really his number one recommendation is we really need to look at improving access to rehab services for this vulnerable population. So in response to this, and actually I have to say previous to this, we also had sort of a need within our center at Toronto. We had clients that were often, if they had confusion written in their actual chart, we actually at Toronto Rehab would say that's an exclusion criteria for rehab in our active rehab unit. And so we questioned that. We thought, really, is that the best way to treat this vulnerable group? So we got together with our physiatrists, our surgeons from acute care to say, can we change their trajectory? And we actually just developed something called the FRAP program. And that was really Fractured Hip Rapid Assessment and Treatment Program. And what this involved, there was 2 prehab phases, and the first was patients that actually get into acute care. As soon as they show up and emerge, they should be operated on within 48 hours, and this is actually now a mandate in the province. And also, we really believe that acute care is not the best place for this client group. If any of you have worked in acute care, you know it can be we can create a lot of excess disability because we don't get the clients up necessarily when we should. So we really felt that if we could get these clients out of the acute care within 5 days, we would. So what I sort of focused more of my research on was the inpatient rehab part, and that's where I have more expertise. We actually focused that on 5 components, one of them being the rehab component, one of them was dementia management, delirium management, and this is actually where Diane and I go back. We actually helped develop the best practice guidelines for RNAO for dementia, delirium, and depression, so it was nice to bring that work to bear in a new population. We really focused on staff education and support because this is actually a new group to care for. So actually some of our physicians were not very comfortable with it, as well with our physiotherapists and our nurses. And there was a big component on patient and family education. And what I mean by that was, instead of telling the family member that after a hip fracture they're probably going into long-term care, we would start saying, actually, get ready, they're coming home, so get prepared. So it was a very different messaging was going on. We pilot tested this actually probably in about 2006-07, and we actually found there were no differences in mobility or discharge for those with cognitive impairment versus non-cognitive impairment. In fact, what we found were some clients with cognitive impairment had forgotten they had broken their hip, which actually we used to our advantage. Let's get up, let's get going, and let's get out of here. And that message was well received by everyone. We then got a CIHR grant to try to, it was a pragmatic trial. We tried to implement it into 2 other sites. And actually, they were very eager to try this. We were very fortunate to have some good outcomes once we trialed it into 2 different settings. There was significant improvement in the indoor walking for patients in the intervention group, and also they were more likely to return home than the control group. So I'm just giving you some background because I think what's important is that first, persons with cognitive impairment are given a chance at rehab, and then we were interested in looking at also the effects of what happens when they go home. We also noted, because this is very important in my work, because I am a nurse, what's it like for the staff caring for this group if you've not cared for these people, for persons with dementia before? And we did find that there was more satisfaction once staff were actually informed how to care for this group well, and they had less work stress post-intervention when we were able to provide them support to care for this group. I need to let you know that in the model of care, and I didn't highlight this, we often hire an advanced practice nurse with expertise in the area to really work with each person on the unit to really look at better ways of assessing what are the needs of persons with dementia and how do we actually get them to achieve their goal of going home. So there's a lot of actually one-on-one teaching, mentoring. I really believe knowledge translation is expensive. It's very hard to change behaviors and attitudes of staff if we actually have been practicing a certain way and for 20 years. It's pretty challenging to say, let's do something different. So then I guess this is really the crux of the presentation. What happens when they go home? What kind of outcomes were we seeing? So when we did apply for our CIHR grant, we did say, let's look at 3 and 6 months later. Let's try to follow our clients and see how they manage once they go home. Because we want to know if there are any predictors that we can modify. What are some of their needs? Do we need to have more services at home once they return home? Because I think there's a bit of a concern if we get them back and they're able to walk, what kind of burden might there be on the caregiver? We're concerned about that as well. So our major aim was just to determine the predictors of independence of activities of daily living, functional mobility, and recovery to pre-fracture mobility status among older adults post-discharge from the inpatient rehab post-hip fracture. So it was a prospective study. We actually had a sample of 149, so we did a pretty good job of actually keeping in touch with them all. We followed them for 6 months, and we actually asked, many of our clients did not have cognitive impairment, so were able to tell us how they were faring. We did use the FIM score, which has a validity for proxies as well. So for clients that weren't able to tell us, we actually were able to phone and ask their family members how they were doing as far as functioning at home. We used the FIM. We also used something called the New Mobility Score, which a physiotherapist kind of created, which is really about reintegration into, walking indoors, walking outdoors, and shopping. So it gave you a better sense of how they really were managing once they were back home. This is I'm sorry, I didn't realize how hard that is to see. But at the end of the day, the intervention group, there were 63, and there were 69 in the control group. So we actually were able to maintain most, and some clients did go into long-term care in both the intervention and control group, but not too many. Based on the literature, we knew there were certain factors that would influence recovery at 3 and 6 months. Pre-fracture functional status is very important. So we really wanted to get a sense of how did that influence recovery. Also, number of comorbidities. This in itself is fascinating. I do work with Nizar Mohammed, and I actually asked him, who's our surgeon, how's it going? I saw him about a month ago, and he said, well, Kathy, we used to work with persons with 80 that had cognitive impairment. Now we're working with persons that are 90 with cognitive impairment, depression, and multiple comorbidities. So I think we're just seeing more and more complex clients that are showing up, and we have to figure out how to, best care for them. So I think, again, the complexity of multiple chronic conditions are here to stay. We looked at discharge from rehab. We were interested in looking at their cognitive impairment, and we used the mini mental status exam for that. And we also looked at pain reported, because there's a lot of evidence that if people are leaving the hospital with pain, something's going on, that perhaps we haven't managed their symptoms well enough, and that might influence their long-term care outcomes. And we also were interested in the use of gait aid, because again, there's some there's some references in the literature that if they're leaving with an aid, again, perhaps they're going to probably have some longer-term disability outcomes. Our outcome variables were the same that we used when the person was inpatient, which was the motor FIM, and that was the independence in ADLs, the functional mobility, and pre-fracture mobility, which I spoke a little bit about. So for those of you that maybe can't see this very clearly, we looked at, we broke the groups down to no cognitive impairment, mild cognitive impairment, and also severe. And severe is less than 14. No CI was greater than 24, and then everyone was in between. So we didn't have a lot of clients, as you can see, with cognitive impairment, but we had enough that we could sort of make some analysis. The mean age of this population, which, by the way, we collected this data about 3 years ago, was about 81 years old, and I'm going to tell you that they're probably older by now. Major percentage of them were female, 77%, and most had 3 or more comorbidities. And of interest, about 68% had a history of falls. So again, there's something there about trying to prevent falls if possible, because that's definitely, this population has fallen before. So again, we did descriptive statistics, and we also did multi-level mixed effects, multivariate regressions to determine the predictors of longitudinal change. So when we looked at this, sure enough, some of the predictors that we found in the literature did come to bear. Requiring wheelchair at discharge did influence some of our outcomes at 6 months. Pain reported at discharge as well. Again, what's happening with that? There's probably underlying comorbidities influencing. Severe CI at discharge also did influence functional ability and independence. And so I'm going to just sort of highlight that. So the 4 major, and also the other one was pre-fracture functional impairment. And in fact, that was the most significant predictor of how people did at 6 months. And for us, this was actually kind of an interesting story. So we actually looked at the effects of the cognitive impairment at discharge versus their pre-fracture functional status before the hip fracture. And in fact, that was much more significant, was how they were doing before they had the fall. Were they up walking? Were they really just hanging out in the living room and not really going very far? So what were they able to do? Well, why this is important is because we often use the idea that if they have a cognitive impairment, they can't be rehabbed. But in fact, our data is showing exactly the opposite. That didn't make a difference to how they were managing 6 months later. The major contributor was their premorbid function. Higher pain rating at discharge, like I talked about, also influenced the rating. And severe CI at discharge was also an issue, and also gait aid used. So for those of you working in rehab right now, you can help me understand why pain and also, like I said, gait aid use at discharge will influence. We did look at some trajectories for the different types of cognitive impairment. As of course you can tell in the dark line, no CI definitely influenced the trajectory is higher. They ended up having higher scores with all our outcome measures, so they were able to be more independent. They were able to walk and transfer better, and they were able to, for instance, go shopping quicker than the rest. You'll see with some of our clients with moderate to severe, there was actually a bit of a decline in their abilities to get around 3 months. And that also made us wonder and sort of stop and say, hey, maybe that is a time where we should be thinking about encouraging rehab at home. What's happening at 3 months post-discharge? And again, maybe we can have an interaction after, but I know in our Toronto area, we do not provide rehab at home necessarily. There's no set programs. And so we're starting to wonder, maybe we need to provide some rehab at that time. So our major conclusions, pre-fracture functional impairment was more strongly associated with poor function and mobility outcomes than was the influence of cognitive impairment on these outcomes. And our findings also suggest different recovery trends over time for participants based on their level of CVI, their pre-fracture functional status, their pain status, and use of wheelchair. And also we did find a significant effect, by the way, if you were in the more intensive rehab, like in our trial, than those that were in the control group. So that little, obviously more rehab while you're able to within the center also influences recovery at 6 months. I think what's important is all participants with CI, regardless of their severity levels, their outcomes at 6 months were almost identical at 3 months. So then that's interesting. Maybe we better find out, can we boost something at 3 months? Because at 6 we saw similar trajectories. So some of the implications when looking at long-term care mobility outcomes for this population, pre-fracture functional limits recovery, not their cognitive impairment. And that findings of the study indicated that if inpatient rehab benefits are to persist, maybe we need to have some sort of rehab in the home, tailored to the individual. So our next question is, well, what happens if we keep following our clients? So we actually did get an amendment. We actually asked and tried to follow our clients for 24 months to determine, because now I'm more interested in the fact that once these clients go home, and they're there for a longer time, what might happen to the caregiver? And we also are much more interested in other outcomes. We often look at sort of function outcomes, independence of the activities of daily living, but I've started thinking about more like quality of life and reintegration into normal living. Should we be looking at measures that speak more to participation for this group? So we continue to find the clients and phone them and try to keep them enrolled. Our N was only 52. We actually did find, we followed up to 90 of our clients, but in fact, although many of them didn't have caregivers, so they couldn't fill out the caregiver burden scale, so I don't have data for them, but I do have data on everyone for trajectories. So we followed them at 24 months. We continued to use proxies or the individual to phone and find out how they were doing. This is perhaps a little bit better, but our sample at 2 years was 90 people, and at the end of the day, though, only 52 were able to participate in some of the analysis I'm going to share with you, because some of the caregivers actually, because some of them didn't have caregivers. Some of these clients were living very independently at home, and so that's why we had a smaller sample size. When we looked at the data to say what other people have used and looked at, whether researchers have looked at 2-year status, often they looked at admission scores, again, around the pre-fracture functional status, the number of comorbidities, and also maybe their social interaction, because I was trying to get at now their reintegration into normal living. So what other factors might influence how they get back? We looked at discharge, person's cognitive impairment, and we were interested in 24 months post-rehab, the influence of functional and ADL abilities on their ability to reintegrate into normal living. Other variables of interest was the caregiver's health status. Again, I think there's not a lot of light shone on the fact that this client group perhaps is burdensome, and how does it fare if you're a caregiver? So we started asking questions about caregiver burden, and we were also interested, like I said, in looking at reintegration into normal living. And if you don't know the reintegration to normal living index, it actually has 2 subscales. One's more focused on physical function, like mobility, self-care activities, and one's more focused on sort of social areas, which are things like the role in the family, the comfort with relationships, ability to handle life events. So again, we thought that was actually quite appropriate for some of our persons with dementia. So our patient demographics is 24 years. The mean age sample continues to be about 80 years old. Of course, similarly, we have 77% female. And our RNL scores was 33 out of 44 on average, which actually is moderately high. So people were feeling, for the most part, that they were reintegrating into normal living. When we look at changes in outcomes from admissions through to 24 post-discharge, this is what we've found. You'll notice similar trajectories from, and I have the 3 and 6 month embedded in here. Those persons without CI, again, obtained higher FIM scores. They were able to get back to shopping, move around outside a little more often. Those with severe CI, you'll note that according to Independence and ADL, they sort of flatlined at around 3 months, a little bit of an increase. Functional mobility, which is the second column, again, they actually started increasing quite significantly, sort of towards the 2-year time point. And then those environmental mobility, again, those with severe cognitive impairment sort of were a little bit on the trajectory was actually the same. And then when you looked at moderate CI, again, you see some different trends, but for the most part, there's a slight improvement up to the 24 mark, not as much leveling off. When we look to see about our reintegration to normal living and what influenced that, in fact, there were quite a few different variables that influenced the person's ability to reintegrate into normal living, like we were assuming. So at the end of the day, we found that pre-fracture functional impairment was important, cognitive impairment, social interaction, and activities of daily living, functional mobility, and caregiver burden. They all made a difference, actually, with reintegration into normal living. So we really found that, again, different recovery trends over time for different participants based on their level of CI and pre-fracture functional status. So not everybody obviously followed the same curve. I was just showing you the means. Most importantly, caregivers who reported less burden were more often caring for hip fracture patients who were better reintegrated into the community. So we did find, but the problem here is, of course, that it is we took that at one point in time as cross-sectional data, so we don't know what comes first. Do you reintegrate into normal living easier and then caregiver burden is less, or is it the other way around, which comes first? So we're not sure, but we realize that if you have, as a caregiver, less burden, that persons with hip fractures were better reintegrated into the community. We also found that more cognitively impaired and functionally impaired the older adult was at baseline, the less fully they were able to reintegrate back to normal living. So we also found that if you were more impaired, that it is a little more challenging to reintegrate into normal living, to be involved in those social relationships and also the self-care. So some implications. We feel that we need to develop interventions targeted within the first 3 months post-discharge based on some of our trajectories. And we need to have more careful attention paid to the burden placed on the caregiver, especially if the older adult has functional and cognitive impairments. So I think this might be one of the first studies that has shown an association between the two. We have to be careful, and I think with again, this isn't even just for persons with hip fracture, but we are sending a lot of our very frail older clients with multiple chronic conditions back home. And as you know, we don't necessarily have the supports in place for the client, let alone the caregiver. So I think we have to really start thinking about how are we going to change community care so that they can sort of get through the day and manage and not to be too burdened. So when we start thinking about then, what would we need to do to provide good rehab once persons with cognitive impairment go home? We actually decided to do a systematic review because we could not find the literature out there that provided some good guidelines. So we're thinking about the next study, the next treatment, what's out there. So I had a postdoc, Paula Van Wyck, and we got money from TVN, which is the Canadian Frailty Network now, to look at post-discharge rehab interventions for older adults with cognitive impairment following a hip fracture. We thought, let's see what's out there and perhaps create a new study of sorts. And so the researchers, again, I work with a great team, and have a little sip here. And so we were able to take on this systematic review. So the primary question was to evaluate the evidence on the effectiveness of community-based rehab post-hospital discharge for older adults with CI following a hip fracture, and to identify physical recovery outcomes and measures used in previous studies. The norm is to have 2 independent reviewers, and that's what we did. We screened the titles and the abstracts. We were looking specifically at rehab intervention. Community at home component was important. Persons had a cognitive impairment and, of course, a hip fracture. We assessed the methodological quality studies, and we were looking, of course, at both RCTs and non-RCTs. Because, of course, if you know, there's, of course, a big controversy right now saying, let's start looking at pragmatic trials. In fact, I'm sure the people here in Ottawa, there's the experts, looking at different methods to evaluate groups instead of RCTs. We actually looked in the literature, and of course, we start with a huge number and get overwhelmed, but luckily we were able to exclude quite a few. And in fact, in the end, we really only found 3 articles that had looked at this group, and usually it was a subpopulation within the study, not necessarily just focused on persons with cognitive impairment. And that's really how the literature has gone with most of the work with persons with cognitive impairment and hip fracture. They're just a sort of special subgroup. HESCO was one of them in 2000. They looked at a geriatric inpatient unit, and they actually had inpatient physical rehab at home, cognitive rehab. They did discharge assessments, and there was inpatient, and then they also did 10 in-home physiotherapy visits post-discharge. They don't, by the way, provide a lot of information on what they're doing in those physio appointments, but they were doing something. Xu et al. At 2012, again, most of these studies, by the way, it's much more multifactorial, and it starts within the inpatient unit and just continues on in the home environment, which probably makes sense. Began prior to surgery with a geriatric consultant, modifications or development of the rehab care plan based on the individual and their abilities, and then there are 6 components of the intervention. There's an inpatient assessment, inpatient physical rehab, daily geriatric nurse, discharge assessment, home assessment prior to discharge, and this time there was 8 in-home RN visits within 3 months, and 3 in-home physio visits. So a real sense of trying to work as a team, interdisciplinary, figuring out the issues, because we know there are probably many of them, especially with clients with multiple chronic conditions, and there's many symptoms we have to deal with. Mosley et al. Was the 3rd study, and they had rehab during inpatient, and they had exercise regime post-discharge. And there was 2 components. They had a physical rehab, which was 1 hour, 2 times a day for 16 weeks, and 8 in-home physio visits. So you get a sense that there is a bit of a follow-up for these clients. And it's of interest, it happens as soon as they go home, and we're wondering, is that the best time, or perhaps a little bit later, where we saw more decline at 3 months. Perhaps we can prevent the decline, I guess, if we start right after they go home. So I guess the discussion from this paper is we thought that there really is a positive outpatient rehab interventions for older adults with cognitive impairment and hip fracture. At least there isn't much in the literature yet. Primary focus has been on inpatient among the studies, emphasizing the care needs for older adults once they go home. And our included studies did not have studies designed specifically for this population, but again, it was more of just a subgroup analysis to see how they would fare. The results suggested that interventions with community-based post-discharge 1 year later are effective in improving various physical function outcomes, mobility, and ADLs. So for those that were in these trials, in these 3 studies, they actually did quite a bit better. Insufficient evidence, though, to indicate the effectiveness for older adults with CI and hip fracture to live in their homes long-term care. So we don't really have all the answers yet. So I think in conclusion, from these studies, we found that it was important, these community-based rehab components. It did seem to make a difference with physical function, mobility, ADLs, but we're still not clear about what best components will make up the intervention. We know that starting early probably makes sense, involving an interdisciplinary team if possible, and involving support for family caregivers. Again, this was actually missing, but we decided and added that this should be part of the actual plan. Summary from this work, which has been about, I guess, 10 years, looking at these different areas. Persons with cognitive impairment can be rehabilitated following a hip fracture. 6 months after the fall, the greatest influence on functional outcomes really is their premorbid status. 24 months later, differences are seen in mobility and ADL with varying degrees of cognitive impairment, but they're still at home. Caregiver burden is related to reintegration into normal living for persons following a hip fracture, and burden is higher for those caring for somebody with a cognitive impairments, and also actually if they're actually more functionally impaired. And very few resources for persons with a hip fracture following inpatient rehab and their caregivers is available today. So that is what I'd like to end. If there are any questions.
Do we have any questions from anybody online for Dr. McGilton? We'll take questions from external sites first. Not hearing any at the moment. Please feel free to ask in a moment. How about from our audience present here? Are there any questions? I have one. I'm very interested in the 3-month criteria. I like hearing that. And I'm aware that Dr. Perry is working here, Jeff Perry, on identifying at-risk seniors being discharged from eMERGE, and has been working also in a multi-site trial. So I would like to be able to share this with Dr. Perry as well. Also, did you happen to look at any osteoporosis or?
So thank you. So I guess number one is at risk, and I think that's actually an excellent point. I was showing you trajectories sort of at the means of the different individuals, but I think individuals definitely are at risk, and I think we did not go through any sort of high-risk assessment to determine who really will be needing more assistance once they're at home. But I think this is a very, very important area to go into because we only have so many resources. So to be able to say, other than pre-morbid function is important, that if you really didn't have a lot of function prior, you're probably at high risk. We need to start looking at things like vulnerability at home. Do you have any support beyond just the physical, as well as that's quite important. As far as osteoporosis goes, I did not look at that. Susan Jagwell's program of research really does focus more on that component, but I think that is important, and it's probably part of the frailty issue that we did not specifically capture here, but I think that would be important for future work. Yeah.
Thank you very much. Wonderful presentation. I just wanted to ask you a few questions. First one is I might have missed it